we are starting with otology. Before dealing any organ in the body, we should understand about the anatomy of that particular part, embryology of that particular structure. So we are going to start with embryology of the ear, followed by anatomy of the ear. Then only we are going to enter into pathology of the ear proper. So be with me, we are going to start with the journey of embryology of the ear. Now, before learning about the embryology of the ear, evolutionary wise, this ear is very much important, because previously some basic species doesn't have an external ear and middle ear. Inner ear is mainly responsible for balance only. So the hearing mechanism is well developed only in humans. Some precursors of human beings don't have much well developed hearing. So external and middle ear are recently formed structures. They have a separate embryology because they have evolutionary wise very newly formed structure, whereas inner ear is being present right from the basic fundamental organism. It has separate embryology. So we'll start with the embryology. External and middle ear has origin from pharyngeal arches. The inner ear has origin from neural ectoderm. Now, what are the important structures in external middle ear? Pinna, external auditory canal, tympanic membrane, middle ear cleft. In inner ear, bony labyrinth, membranous labyrinth. Now you look, we'll start with the pharyngeal arches forming external and middle ear. Any pharyngeal arch, there are totally 1, 2, 3, 4 and 6 pharyngeal arches. Fifth one will become rudimentary. Now, any pharyngeal arch will have a bulk of the thing called mesenchyme. Externally, all the pharyngeal arches will have a cleft. That cleft name is called ectodermal cleft. Internally, there will be endodermal outpouching. Clear? Yes. The arch of interest concerned with otology is only first and second pharyngeal arch. These two pharyngeal arches will form the important structures of the external and middle ear. Now, from the ectodermal cleft of first arch, external auditory canal will be forming. First endodermal outpouching will form tubotympanic recess. Clear? Whereas the first pharyngeal arch mesenchyme will form malleus and incus, which are the bones, tensor tympani, which is the muscle. The second arch will form stapes, which is a bone, stapedius, which is a muscle. So this is how the pharyngeal arch will give rise to the external and middle ear structures. Clear? Now see here, this ossicles are forming from the mesenchyme, this external auditory canal developed from the cleft, whereas what will happen to the tubotympanic recess? This tubotympanic recess will give rise to the middle ear cleft. The proximal part of the middle ear cleft, that is tubotympanic recess, and then distal part of tubotympanic recess will form Eustachian tube and middle ear cavity respectively. Clear? Now you look, the pharyngeal arches are there. In pharyngeal arches there will be mesenchyme, ectodermal cleft, endodermal outpouching. Mesenchyme will form the bones and the muscles. Ectodermal cleft will form the external auditory canal. Endodermal outpouching will form the tubotympanic recess which give rise to Eustachian tube and middle ear cavity. Which are the leftover ones? The junction of all these layers will meet at a point that is called as tympanic membrane. See here, this is ectoderm, this is mesoderm, this is endoderm. All these three will meet at point that will give rise to the tympanic membrane. That will give rise to the tympanic membrane. So tympanic membrane has origin from all three layers. So apart from these three structures, there is pinna. The pinna will develop from mesenchyme only. Will develop from mesenchyme of first and second arch. Okay. So this is how the pharyngeal arches are giving rise to the structures of the external and middle ear. Got it? Yes. Now we can enter into the neural ectoderm forming the part of the inner ear. So the neural ectoderm will start with a mound of neural ectodermal epithelial cells that is called otic placode. Okay. Just below the otic placode there will be formation of otic pit. Okay. Once the otic pit forms, this otic pit will separate from the otic placode part and there will be formation of otic capsule outside and then otic vesicle inside. Clear? So first otic placode, then otic pit, then it will differentiate into two important structures, otic capsule and otic vesicle. This will happen by 4 to 5 weeks. Clear? Fine. This otic capsule will form the bony labyrinth. This otic vesicle will form the membranous labyrinth. Clear? Fine. Now this will happen by 5th week. Okay. So 5th week this membranous labyrinth will differentiate into two parts, mainly pars superior and pars inferior. Now this pars superior will develop into semicircular canal and atricle. So semicircular canal and atricle will have separate embryological aspect. Then saccule and cochlear duct will form from pars inferior. Clear? So pars superior give rise to semicircular canal and atricle. Pars inferior will give rise to saccule and cochlear duct. Clear? Now there will be formation of cochlear turns by 8th week. Formation of cochlear turns by 8th week. Then within the cochlear turns there will be formation of interscalar septa within the cochlea by 22 to 23 weeks. It will start from the 4th week duration with the formation of otic placode and otic pit. Finally it will be forming the interscalar septa by 20 to 23 weeks. So by 23 weeks the ear will be fully formed. That's why they are saying in Mahabharat, by 20 weeks of gestation itself the son of Arjuna can listen to the words of Chakravyuha. Clear? So that's why the audiological embryology is very much important. You just remember the Mahabharata story. So half story, that is formation of Chakravyuha, the son of Arjuna will know. The coming out of the Chakravyuha he doesn't know because he slept in between. So 23 weeks itself he knew what is going to happen in Mahabharata. Clear? So you just remember like this, by 23 weeks of gestation almost entire ear will be formed. Okay, this pattern of the formation of the ear is very important because the pattern is very important. If you know the pattern you can understand the important embryological diseases of the ear. Now otic capsule we know. So otic capsule will give rise to the bony labyrinth, which is a part of temporal bone. It's a part of temporal bone. These are parts of the temporal bone: squamous part, tympanic part, petromastoid part. So you can include styloid process and zygomatic process in excess, but important parts are squamous, tympanic, petromastoid. You can divide petromastoid into petrous and mastoid part. Okay, so these are the parts of the temporal bone, whereas the bony labyrinth is a part of the petrous part of the temporal bone. Clear? So we have seen about the embryology of external middle ear and inner ear forming from otic capsule and otic vesicle separately. Now let's jump into a question which was recently asked NEET question. Which of the following structure does the saccule develop from? So as we know, saccule develops from pars inferior. Saccule and cochlear duct forms from pars inferior, whereas atrial and semicircular canal forms from pars superior. So we are clear with the embryology part. Now we can go to the disease that is formed as a failure of embryological fusion. Now as I told you, by 4th week the otic capsule and otic vesicle will have its origin. If the otic capsule and otic vesicle doesn't form, the formation of the ear stops at that junction itself. It will be hell for the child. There will not be a bony labyrinth, there will not be a membranous labyrinth, there will be no hearing, no balance mechanism happening in that particular child. The life will be hell for the child. Life will be hell for the child. So I call it as Mike Hell deformity. So hell like life for the child is Michael's deformity. Now look, otic capsule is formed but otic vesicle is not formed, which means that bony labyrinth is formed but membranous labyrinth within the bony labyrinth is not formed. So this is called Bing Siebenmann deformity. Clear? Now from the otic vesicle, pars superior alone formed, pars inferior not formed. Pars inferior alone not formed, which means that cochlear duct is not formed, so no hearing. Okay, and also atrial and semicircular canal will be formed but saccule is not formed. Okay, saccule and cochlear duct is not formed, so this deformity is called Sheeby's deformity. Okay, now coming to the cochlear turn. Okay, if the entire cochlear turn is absent, it is called Alexander dysplasia. So if only 1.5 turns are present instead of 2 3/4 turns, the cochlea should have 2 3/4 turns. Instead of 2 3/4 turns, only 1.5 turns of cochlea is present, means it is Mondini's dysplasia. So here the easiest and very less complicated disease is Mondini's dysplasia. This is the only disease where you can do cochlear implant as a treatment option, whereas for other diseases, so you should try only brainstem implant. So Mondini's deformity, it is very less severe, so you can try a cochlear implant. Other deformities you should try only brainstem implant. Clear? Yes. Now let's summarize the embryological aspect of entire external, middle and inner ear. So pinna forms from mesenchyme of first and second arch. Okay. External articular from first ectodermal cleft. Middle ear cleft and Eustachian tube forms from the tubo-tympanic recess, which is actually forming from first endodermal outpouching. Tympanic membrane, 3 layers. Malleus and incus forms from mesenchyme of first arch. Stapes forms from mesenchyme of second arch. Now the thing which I didn't tell you these many times, if there is two separate embryological origin, there will be meeting point of these two embryological origins. That meeting point is the stapes footplate and annular ligament. Fine. Now the stapes footplate and annular ligament is a part of the middle ear, but the embryology is from the otic capsule. See, this is the only part which is present in the middle ear, but as embryology similar to that of the inner ear. I'll come again. Stapes footplate and annular ligament. For example, malleus, incus, stapes suprastructures. All these forms from the mesenchyme of first and second arch, whereas stapes footplate and the ligament adjoining the stapes footplate will form from the otic capsule, which is the origin for inner ear bony labyrinth. So this is the thing that you should understand. If you understand this, you can understand the otosclerosis pathology very easily. Okay, we'll discuss in detail when we study about otosclerosis. So this is the very important point that you need to understand. Fine. So membranous labyrinth forms from otic vesicle. Fine. So this is how embryology works. Now, based on the external ear and middle ear embryology, we can discuss a few diseases such as pre-auricular sinus and coloral fistula. So the first and second arch mesenchyme fusion defect will result in pre-auricular sinus like this. So this pre-auricular sinus will come in front of helix. Clear? So if it is symptomatic, surgical treatment is needed. That is excision of sinus tract. Whereas if it is silent, no symptom is present, you can wait and watch. Clear? So pre-auricular sinus is an embryological abnormality which happens due to defective fusion between first and second arch mesenchyme that results in formation of a sinus tract. The sinus tract sometimes be infective, causing discharge leaking from the sinus. So if that is the case, you should do surgery for that particular condition. If not, you should wait and watch. Clear? So coloral fistula is again a first ectodermal cleft defect. Okay, here one end at the floor of external auditory canal, other end over the neck. See, this is the another end. So the ear end will be present at the floor of the external auditory canal. So the first ectodermal cleft will give rise to the external auditory canal. So if it is defectively fused, it results in coloral fistula. Again, if it is symptomatic, you should do surgical removal. If it is silent, you can wait and watch. Okay, fine. So we have dealt about the fusion defects. Now we can enter into syndromic defects associated with the first arch, that is the external and middle ear defects. Okay, now a newborn had hypoplasia of mandible and zygomatic bones, malformed external ears, slanted palpable fissure, abnormality in the development of which of the following pharyngeal arches will most likely lead to the given condition. As I told you, the first and second arch will give rise to external middle ear. Okay, if the first and second arch is defective, there is a particular syndrome that will not only have ear defect, because the first and second arch, the first arch is mandibular arch, it will give rise not only to the ear, it will also give rise to the mandible and important aspects of the face. Okay, second facial nerve, facial arch, it will give rise to important structures of the face. So if these two arches defective, okay, mainly it means the mandible and zygomatic bones. So in this question, the defective arch is pharyngeal arch number 1. Okay, if they have given there is defective some facial muscle development or something relevant to the second arch, if it has been given, means we can write it as second arch. So in this question, there is malformed external ears, there is malformed mandible and zygomatic bones. So this is probably a defective first arch syndrome. Is it possible, doctor? Yes, it is possible. There are only two syndromes which is associated with defective first and second arch, but not others. What are the syndromes? Those syndromes are Treacher-Collins syndrome and golden hair syndrome. Clear? Yes. You would have learned about a lot of syndromes in your life. Okay. There will be a lot of hearing loss associated with those particular syndromes, but most of the syndromes will be having sensory neural hearing loss. These are the only two syndromes which are associated with conductive hearing loss. because here there is defective first and second pharyngeal arch formation. So what are the features of Treacher-Collins syndrome? You just look into this picture. Downward slanting of lower palpebral conjunctiva. What else? There will be microtia. See here, this is mandible is defective, so there will be midfacial hyposomia. Clear? Yes. So these are the features of Treacher-Collins syndrome. This syndrome, there will be conductive hearing loss, but there will not be any sensory neural hearing loss. Clear? Yes. Now entering to the golden hair syndrome. What are the features of golden hair syndrome? See, this child is having a retrognathia, pre-auricular tag, then there is epibulbar dermoid of the conjunctiva, okay. Then one half of the face is affected. This is hemifacial microsomia. These are the four features: epibulbar dermoid, pre-auricular tag, retrognathia, hemifacial microsomia. Clear? So this is how Treacher-Collins syndrome and golden hair syndrome will work out. Fine. So we have seen about embryology, we have seen about few diseases associated with embryology. Now we can enter into anatomy proper of the ear. We'll start with pinna anatomy. Pinna will be having an helix, it will be having an antihelix, there will be tragus, there will be antitragus. Okay. Now there is a area called Simba concha. Okay. There is an area called cavum concha. Okay. Now this is the fossa triangularis. Okay. This is the basic representation of the pinna. Now some anatomical variations. See, there is small deflection of the helix. Okay, there is a small deflection of the helix. Okay, that is called Darwin's tubercle. Deflection, this is a normal anatomical finding, it has no clinical significance, it is just a name given called Darwin's tubercle. Fine. Okay. So what else? Let's see about tragus. See, we are having the tragus. Okay, tragus is present. Okay, so if there is tenderness over the tragus, so it is a sign of otitis externa. Sign of otitis externa. Okay, then there is an area called, this is the area, incisura terminalis. Okay, incisura terminalis. This area is devoid of cartilage. Okay, this area is devoid of cartilage, so it is best site for incision. Clear? Yes. So these are some basic clinical points regarding the parts of the ear, that is pinna. Now some important developmental defects we can see. So if there is prominent antihelix, that is called bad ear. So antihelix is defective. Second one is Mozart ear. Here there is fusion of helix and antihelix. Okay, fusion of helix and antihelix. Okay, here another disease called Wildermuth ear. In Wildermuth ear, there will be reduced turns or absent turns in helix. Okay. So if there is antihelix defective, it is bad ear. Fusion of helix and antihelix, it is Mozart ear. The reduced turns or absence of turns, it is Wildermuth ear. Now let's see about the incision associated with ear surgeries. The incision number 1 is William Wilde incision. Incision number 2 is Rosen's incision. Incision number 3 is Lampert's incision. Okay. William Wilde is post-oral incision. Rosen's incision is endomeatal incision. Lampert incision is endoral incision. Clear? So William Wilde incision is post-oral incision. Rosen's incision is endomeatal incision. Lampert incision is endoral incision. These are the three incision that is mainly used for doing surgeries of the ear. Clear? So we have dealt about pinna anatomy and important clinical points. Let's enter into external auditory canal. What is the embryology of external auditory canal? First, ectodermal cleft. This external auditory canal is 24 millimeter length. Okay, fine. Out of which this 16 millimeter and 8 millimeter. The 16 millimeter is bony, 8 millimeter is cartilage. This cartilaginous portion will be having hair follicles. So it is prone for folliculitis or localized otitis externa. Clear, people? Yes. So we are seeing about external auditory canal. It is 24 millimeter length. The cartilaginous portion will be having hair follicles that can result in folliculitis. Now we are going to deal about important two, fissure and foramen. Okay. So the fissure that is present in the cartilaginous portion is fissure of Santorini. That is present in the bony region is foramen of Hashke. Clear? So if there is any infection or malignancy that is present within the premises of the external auditory canal, it can spread to the adjacent structures such as parotid gland that is present immediately below the ear. It will spread through this fissure of Santorini and foramen of Hashke. Okay. This foramen of SJK can also spread the infection to the cranial cavity. Okay. So if only the infection of the external auditory canal, it has been spreading to the cranial cavity, it could have occurred through this foramen of SJK. So we learnt about fissure of Santorini and foramen of SJK. Clear? Yes. Now let's jump into anatomy of the middle ear. First, before learning about anatomy of the middle ear is divided into three parts: epitympanum, mesotympanum, hypotympanum. So this epitympanum has the least ventilation. Mesotympanum has all the important structures. Hypotympanum has only air cells. Okay, that is the difference between three divisions of the middle ear. Okay, fine. Now the middle ear cleft. What is a middle ear cleft? Middle ear cleft includes middle ear cavity, number 1, eustachian tube, number 2, and mastoid air cells, number 3. So middle ear cleft is nothing but the middle ear, eustachian tube, and mastoid air cells. These three will form the middle ear cleft. Okay. So this middle ear and mastoid air cells will be joined by adductus ad antrum. Okay. This middle ear is joined with the nasopharynx with the help of the eustachian tube. That's all we should know about the basic divisions of the middle ear. Now we'll start with walls of the middle ear. Any house has 6-dimensional walls: lateral wall, medial wall, anterior wall, posterior wall, roof, floor. Likewise, our middle ear is also having 6 dimensions. We'll start with lateral wall. So we are entering through the pinna, we are entering into the external auditory canal, we are reaching the tympanic membrane. The other side of the tympanic membrane is the medial wall of the tympanic membrane, whereas it is the lateral aspect of the middle ear. The medial wall of the tympanic membrane is the lateral aspect of the middle ear. So if we want to learn about lateral wall of the middle ear, we should have an understanding about the tympanic membrane. So what are the parts of the tympanic membrane? This is a pars tensa, this is a pars flaccida. Okay, there is a prominence of malleus, that is lateral process of malleus and handle of malleus, that we could see. Okay, the tip of the handle of malleus that is forming the projection is called umbo. So the tip of the handle of malleus forming the projection, it will have little bit projected appearance compared to the other areas, hence why it is giving rise to the formation of cone of light. Okay, the reason for cone of light is the particular umbo is giving a projected appearance compared with other areas of the tympanic membrane, that will have a mounted appearance of the light, that is cone of light appearance. This is how a normal tympanic membrane will look like. Okay, the cone of light should be present, all the structure should be like this. If it goes like this, it is normal tympanic membrane on examination. If it is not happening, this is a retracted tympanic membrane. Okay, so what are the signs of retracted TM? First, we just look into this. When comparing with the normal tympanic membrane, this tympanic membrane is, first of all, no cone of light is present. Then it is dull and lusterless. Okay, see, it is very dull and lusterless. Then there will be prominent malleus. Then foreshortened handle of malleus. There is foreshortened handle of malleus. Okay. Now you look into this, there is some sickle shaped malleolar fold just on either side of the handle of the malleus. Sickle shaped malleolar fold. These are the signs of retracted tympanic membrane. Clear? Yes. We have done about lateral wall. We can go to the anterior wall. We can divide the anterior wall into three halves. Upper 1/3, middle 1/3, lower 1/3. Okay, fine. The upper 1/3 will be having a canal for tensor tympani muscle. The middle 1/3 will be having a canal for Eustachian tube. The lower 1/3 will be having a Glaserian fissure. Glaserian fissure is called petrotympanic fissure. Okay, over the lower end of the Glaserian fissure, you will be having a structure called Canal of Hoogier. This Canal of Hoogier is the exit point for Cauda tympani nerve. Clear? So we are seeing about the anterior wall of the middle ear. It is having upper 1/3 for canal for tensor tympani, middle 1/3 for Eustachian tube, lower 1/3 exit point for Cauda tympani in the form of Glaserian fissure and canal of Hoogier. Clear? Yes. So we are done about the anterior wall. Now we can enter into the medial wall. This medial wall is having a promontory. Over the promontory we will be having the tympanic plexus of nerves. Okay, so just posterior superiorly we will be having a foramen ovale. Then posterior inferiorly we will be having a round window. So this is the oval window. This is a round window. Just above the oval window you will be having the facial canal, or otherwise called fallopian canal. Okay, so just above the fallopian canal you will be having the prominence of lateral semicircular canal. Clear? Fine. So we are having the medial wall. The medial wall is having promontory, prominence of the cochlea. So posterior superiorly you will be having oval window, posterior inferior you will be having the round window. Just above the oval window you will be having the facial canal or fallopian canal. Just above that you will be having prominence for lateral semicircular canal. Now just anterior superiorly you will be having the processus cochleariformis. This processus cochleariformis will be a hook like structure. It gives attachment to tensor tympani muscle. So attachment to the tensor tympani muscle. So that's all about the medial wall of the middle ear. We have seen about lateral wall, anterior wall, and we have seen about medial wall. Clear? Yes. Now before entering into the posterior wall, we need to have an understanding about the ossicles of the ear. Okay, so you need to have a clear depiction of the ossicles of the ear. Now you look, this is the pinna. We are entering into the pinna. Once we enter into the pinna, we will be seeing the tympanic membrane like this. See, so this is the tympanic membrane. So it is present at the end point of the external ear. Once we breach the tympanic membrane, we can enter into the middle ear, showing the ossicles. See, the ossicles are being shown. So what are the ossicles that we know? We know malleus, this is the incus, this is the stapes. So three ossicles, malleus, incus and stapes. Okay, now so let's look into each ossicle separately. Now you look, this is our malleus. So malleus, the handle of malleus is having attachment to the tympanic membrane. Attachment to the tympanic membrane. This is the lateral process of malleus. Okay, this is the head, this is the neck. Okay, now if you are clear with this, we can learn about a space called Prozac space. Okay, so this space is closely associated with our malleus. How? Now just look, so now you look, so when we look at the malleus is having parts such as neck of the malleus. This is the neck of the malleus, this is the handle of the malleus. So this handle of the malleus is having attachment with the pars flaccida over here. Okay, so now we are going to plot the area over here. The area over here is called Prozac space. The area over here is called Prozac space. Okay, now you look, this Prozac space is having a medial boundary as neck of the malleus, lateral boundary as pars flaccida, inferior boundary as lateral process of malleus, superior boundary as this one is nothing but lateral malleolar ligament. Okay, this is nothing but lateral malleolar ligament. Okay, see, this is lateral malleolar ligament which is forming the roof of the Prozac space. I'll come again. We are dealing about Prozac space. This Prozac space is just over here. It is having, it is just over here. It is having pars flaccida as the lateral boundary, neck of the malleus as the medial boundary, lateral process of the malleus as the inferior boundary, lateral malleolar ligament as the superior boundary. This is how a Prozac space has been formed. So now you will be clear with the Prozac space and malleus. Okay, now we can write it down. So malleus is nothing but a hammer like bone. Okay, hammer like bone. It is having a head, it is having a neck, it is having a lateral process, it is having a manubrium or otherwise called handle. Okay, so these are the things that you know about malleus. Now we immediately learn about the Prozac space. So Prozac space, first one is medially and laterally. What you know? Medially is neck of malleus, laterally is pars flaccida, inferiorly superiorly. So inferiorly lateral process of malleus, superiorly lateral malleolar ligament. So why I am telling about Prozac space in brief? Because the Prozac space is the most common site for cholesteatoma. Most common site for cholesteatoma. Clear? So medially, laterally, inferior, superiorly, you will know. Now let's see about the other ossicles. The other ossicle, look, this is the incus. Okay, this incus, if you look, it is having a facet over here. Okay, so this incus is having a facet over here. This facet is for malleus to get attached. So this is incudomalleolar joint. This incudomalleolar joint is nothing but a saddle joint. It's nothing but a saddle joint. Okay, now this incus, if you look at the parts of the incus, just look here. The incus is having this is long process of the incus. This is short process of incus. Okay, this is the facet for malleus, this is the facet for stapes. So incus is the only bone which is giving two facets for two other ossicles. Okay, this facet which is joining with the malleus is the saddle type of the joint. This which is joining with the stapes is a ball and socket variety of joint. Okay, that completes incus parts. We'll also complete the stapes here. See, the stapes is having foot plate and stapes suprastructure. So this is the stapes suprastructure. This is the stapes foot plate. Okay, so the stapes foot plate will be having an anterior crura, posterior crura, okay, and then a annular ligament. So this stapes is the smallest bone in the body. It is having a suprastructure, it is having a foot plate. Foot plate is divided into anterior crura, posterior crura, then annular ligament it is having. Okay, so this is how a stapes has been divided. Clear? This foot plate of stapes will get attached to the oval window. We get attached to the oval window. Clear? So now we know about the incus. Facet for malleus, there is a facet for stapes. There is a long process, there is a short process. Okay, there is also a lenticular process that is present near the articulating joint of the stapes. Stapes, you are having a head, neck, you are having a crura, you are having a foot plate. Clear? Fine. Now muscles is tensor tympani muscle and stapedius muscle. Tensor tympani muscle is related with malleus, stapedius muscle is related with stapes. So incus is not having any muscle. Okay, so it is having the least blood supply compared to other ossicles. Because if you are having a muscle, the muscle will give you some blood supply. So incus is not having any blood supply, so it is least blood supply area, so it is more prone for erosion due to disease. Okay, now tensor tympani muscle originates from the neck of the malleus. Okay, it has also attachment from the canal for tensor tympani on the anterior wall and processus cochleariformis on the medial wall. Okay, whereas stapes, so it has attachment to the neck of the stapes and also it is attaching to the pyramid that is present in the posterior wall. Pyramid that is present in the posterior wall. Clear? Yes. So we have done about the important bones and muscles of the middle ear, which is arising from the mesenchyme of the first and second pharyngeal arch. You don't ever forget that. Fine. Now we enter into the posterior wall. So we have seen about Prozac space. This posterior wall, the important structure is the pyramidal eminence. This is the pyramidal eminence. Okay. So if you are having a pyramidal eminence, just above the pyramidal eminence you are having a space called facial recess. Just adjacent to the pyramidal eminence you are having a space called sinus tympani, and the facial nerve and chorda tympani nerve is also running close to the pyramidal eminence. With the help of these two nerves, we are going to study about these two spaces, facial recess and sinus tympani. First we start with the facial recess. What is the clinical significance of facial recess? This is the area of inserting the electrodes to reach round window in cochlear implant, whereas what are the boundaries of the facial recess, which is very important. First boundary is fossa incudis that lodges the short process of incus. Okay, you just remember this. Then facial nerve and then chorda tympani nerve. The recess that is found between these three structures are called facial recess. Okay, so superiorly fossa incudis, medially facial nerve, laterally chorda tympani nerve. I'll tell you with the help of the video of cochlear implant. See here, in this video the incision has been marked and been exposed the mastoid bone. Then we are drilling away the cortical part of the mastoid bone, and then we are drilling near the facial recess. Okay, the chorda tympani is identified, facial nerve is identified, and above the middle ear bone, that is short process of incus, is identified. So the area between these three structures is the facial recess. So facial recess is the area where we are identifying the round window. So through the round window we are going to insert the electrodes of the cochlear implant. So that makes you to understand about the important clinical aspect of facial recess. Facial nerve, chorda tympani nerve, superiorly fossa incudis holding the short process of incus. See, the electrodes of the cochlear implant are inserted into the round window through the facial recess. Okay, fine. So we have seen about facial recess, we have seen about Prozac space that is adjacent to the malleus. Now we can enter into an important and confusing space called sinus tympani. Okay, you just remember that you are traveling in a car. The car is traveling in a highway. It is very smooth as a butter. Okay, suddenly you are getting a speed breaker. What will happen? Your speed will drop down. Now you imagine immediately after the speed breaker you are getting a big rain pit like this. Okay, so what will happen? This rain pit will make you still more reduce your speed. Similarly, if you consider this to be the middle ear, suddenly entering into the medial wall of the middle ear, there is a prominence like a speed breaker, that is our promontory. There is a prominence like the speed breaker in this highway, that is promontory. Just after the prominence there is two bony prominence, that is Ponticulus and subiculum, that is arising just posterior to the promontory. So which gives a space called sinus tympani. Okay, so if you remember this story you will not forget the landmark and relations of the sinus tympani. I will explain you with the help of the diagram. See, this is the other side of the road. You are entering from the middle ear. This is the medial wall having a promontory. This is Ponticulus. This is subiculum. This is the sinus tympani. Okay, I'll compare this with the help of a diagram. See here, this is the middle ear cavity. We are entering into this is the middle ear cavity. So the entire thing will be the middle ear cavity. The smoothness is there. Now entering into the medial wall, there is a prominent speed breaker called promontory. Just arising from the promontory, there is ponticulus and subiculum. Ponticulus and subiculum. So between these two bony landmarks, there arises the sinus tympani. So the sinus tympani is over here. Clear? So if you go little bit posteriorly, there is a prominence, that is the pyramidal prominence. So pyramid of the posterior wall is also present posteriorly. So anteriorly promontory, posteriorly pyramid, superiorly ponticulus, inferiorly subiculum. Okay, I have told you the facial nerve is closely related to the pyramid. So laterally it is related with facial nerve, medially it will be relating with the posterior semicircular canal, which is not seen over here. Okay, see, this is actually posterior semicircular canal, which is not very prominent over here, but that is the boundary. Okay, now let's write down the boundaries of the sinus tympani. Anteriorly promontory, posteriorly pyramid, superiorly ponticulus, inferiorly subiculum, medially posterior semicircular canal, laterally facial nerve. That completes understanding about sinus tympani. Now why it is happening, you just get back to the road. This is a smooth highway. After a rainfall, does any part of this highway is having water stagnation? No, only the pit over here is having a water stagnation. Similarly, if a cholesteatoma spreads to the entire middle ear cavity, it will not be remnant in the middle ear cavity, it will be remnant in the sinus tympani. So even if you do a surgery, the sinus tympani is the most common site for recurrent cholesteatoma. This is the most common site for recurrent cholesteatoma. Okay, got it? Yes, this is the most common site for recurrent cholesteatoma. Yes. So, we have done about the posterior wall and medial wall, which are the most important walls. We have seen about three spaces, that is facial recess, sinus tympani, and previously we saw about Prozac space. Now we will be very clear about the important nuances of the middle ear spaces. So last two things are very easy. Roof of the middle ear is formed by tegment tympani. A lot of tympani words are present in the middle ear. Bone that is present in the roof, tegment tympani. Muscle, tensor tympani. The cavity is called tympanic cavity. The membrane is called tympanic membrane. So the word tympanic means middle ear. Anything that is associated with middle ear, we can call it as tympanic. So the tegment tympani is nothing but a part of the temporal bone that is forming the roof of the middle ear cavity. See here, this is the middle ear cavity. So this is the roof of the middle ear cavity. Okay, this is the roof of the middle ear cavity formed by the tegment tympani. Clear? Fine. So that completes the roof of the middle ear. Now the floor of the middle ear, for you to understand that, you need to know about the relation of jugular vein. The jugular vein will form a bulb-like structure called jugular bulb at the floor of the jugular bulb at the floor of middle ear. Clear? Yes. So that completes the floor of the middle ear. So we'll brush it up with a question regarding the middle ear. Which of the following statement is incorrect? Okay. The stapedius muscle is innervated by cranial nerve. 7. Is it true? Yes, it is true, because stapedius origin from the mesenchyme of the second pharyngeal arch. Second pharyngeal arch is supplied by 7th nerve. Tensor tympani is innervated by cranial nerve 5. Yes, the pharyngeal arch 1 is supplied by mandibular nerve, which is a branch of trigeminal nerve. So that is also correct. Tegment tympani separates the tympanic cavity from the middle cranial cavity. Yes, that is also correct. The tegment tympani may be deficient in up to 15% of people. No, that is not correct. If it is deficient, mean 15% of people, mean many will be having meningitis. The cranial cavity will enter into the middle ear cavity. It will cause a lot of problems. It is only around 5%. Okay, this is the incorrect option. Okay, so that completes the discussion part. Okay, that completes the discussion part for the embryology and anatomy of the ear. To brush it up, okay, external and middle ear, it is forming from pharyngeal arches. Okay, so mesenchyme, ectoderm, cleft, endoderm outpoaching will be varied. So the basic thing is external middle ear forms from pharyngeal arches. Then the inner ear forms from the neural ectoderm. At the meeting point of these two levels, it is stapes footplate and annular ligament. So it is also formed from neural ectoderm, that is the otic capsule. So otic capsule will form the bony labyrinth and stapes footplate annular ligament. Okay, so this is bony labyrinth forming from the neural ectoderm. Okay, it is forming from the otic capsule. It is giving rise to the bony labyrinth as well as the footplate of stapes and annular ligament. The otic vesicle will give rise to the membranous labyrinth. Okay, fine. That's all about embryology. Then pre-auricular sinus is due to mesenchyme, first and second mesenchyme fusion defect. Okay, whereas coloral fistula is due to first ectodermal cleft defect. Clear? Yes. Then we saw about Treacher-Collins syndrome and golden hair syndrome. These are the two syndromes having conductive hearing loss. Then no otic capsule and no otic vesicle, it is Michael deformity. Okay, only 1.5 turns formed, not 2/3, 3/4 terms, it is Mondini's deformity. So it is very severe, it is very mild. In between we'll be having Bing-Siebenmann, we'll be having Sheebies, we'll be having Alexander, that you should remember. So Mondini's dysplasia. Okay, so that's all about the fusion problems. Then we saw about the walls of the middle ear. So lateral wall, tympanic membrane is important, anterior wall, canal for tensor tympani, then canal for Eustachian tube, then exit point for carotid tympani in the form of canal of Hoogier. Then medial wall will be having a promontory, oval window, round window, facial canal, canal for lateral semicircular canal, then process cochleariformis. Then posterior wall, pyramid is important, then 3 spaces, Prozac space, sinus tympani and facial recess. Prozac space, most common site for cholesteatoma, facial recess, insertion of electrodes in cochlear implant for reaching the round window. Sinus tympani, most common site for residual cholesteatoma. That completes our discussion on embryology and anatomy of the ear.